This is a podcast where experts in movement and life tackle current concepts in health and wellness and use science and evidence as the foundation of how we discuss each topic. This is not medical advice, but a sedentary lifestyle is much more harmful, so we should move. The motif experience, where movement and life come together. I'm your host, Dr. Tyler Cuddy-Ford. So we have Li-Zandré here today. So Dr. Philbrook, she has a great story about her journey. So that's mostly, I think, what we're going to talk about today. And then, how she's, how she got here, and the influences that she's gathered from reading, from insights, from clinical practice. Which people don't know. So. She was the lion's share of the one that started primary care, right? And I know Hauck gets all the credit, but actually it wasn't him. So it was Li-Zandré, and then Dan. Of course, Dan is still in it and doing a ton of training. But we couldn't have done it without Li-Zandré. So the grant was significant. And it required a full-time PT, and which we didn't have. So Li-Zandré took half of that. Dan took a quarter, and I took a quarter. And so Li-Zandré really is responsible for setting primary care on the map, really, in the Northwest. So that's something little known. I think she's involved in so many things that's probably just slipped most people's radar. But I wanted to bring that up. We're just for those that are listening and some that are watching. It's really about the motif experience. It's about understanding the current state of physical therapy and not being happy with the status quo. Trying to figure out how to do that and not be negative, but in positive ways. How do we improve the practice of PT? And we're serious about that. And Li-Zandré's just got a ton of insight in how to do that with our students. So she's jumped all in with ClinEd and mentoring students and practicing that way, which I think is her jam, and which gets her excited about practice. So enough of me talking. So let's ask the native South African some questions.
Yeah.
So was there a turning point? So maybe talk a little bit about your training, because I think that's significant. It's legit. So meaning the manual therapy experience you got, and then just maybe what turned you and what shaped the way that you practice now.
Sure. Yeah. Well, thanks for having me. So my journey with PT really doesn't look anything like I had ever imagined, but I know our plans are never really what it is. It's God's plans. But I do really see a way that not only my journey in becoming a clinician, but also my pursuit to change healthcare and the world, really, or just even my little community. But I graduated from University of St. Augustine down in San Diego. Loved my experience. It was super accelerated. It's exactly the challenge I was hoping for. Heavy manual therapy base. I mean, even in our first 4 to 8 months, we were already doing mobilizations and manips and stuff, and it was great. I loved it.
Yeah.
Really would not have done it a different way. I actually toured this building for this program before going there. So it's fun to see the full circle come back. The thing looking back is so heavy focus in manual therapy. Yes, we read research, but we didn't research anything other than how manual therapy is going to help, and literally our hands are going to heal people. And so that's the idea that you have coming out of school, that I am going to help these people in ways that they've never been helped before. And so then my first job, people were getting better, but there was something that I kept feeling like I was missing. And I did tons of extra con ed, what am I missing? they're getting better, but they just end up coming back. And I wanted to know why. Why are you coming back? What did I miss in terms of making you feel empowered that you can keep going on? Met Dan while I was still working at the other organization, and it's like there's something different about him, and started talking with him a whole lot more. Eventually that brought me here, and then into primary care, and I feel like that was the turning point. It made me a way better clinician, an outpatient orthopedic clinician, with my time in primary care. Learned a ton from the physicians, taught them a ton too, so that was really fun to work in that collaborative approach. I think the big turning point, and I think you were there too, was the one day sitting watching Dan treat a patient, and he literally never touched them, and I was like, okay, this is something that I need to know how to do. And primary care gave me those 5 to 10 minute snippets that I could really practice a lot of these things. So practice a lot of not so much motivational interviewing at that time, but it just gave us tons of reps, and I needed that. I mean, I was only 2 years out as a clinician, so that was fun. And then being able to come here and then carry on. Then the other turning point was Promise, and so that was the big other turning point of like, now how do I really know what the patient values and what are they expecting from their care?
So let's go back to the case that we all witnessed in primary care, and first of all, it was a series of articles we read. It was like kind of a boot camp that Dan had put us on.
A little physician room.
Yeah, in a little room, and we're reading articles. So it was you and me and Hauk and Kang, and we're just reading articles. And we came across one, and we've referenced this a ton, but I think it flipped. It flipped me for sure, Dan and Jeff. So all three of us, seasoned. This was. Li-Zandré is not seasoned, so that would be one thing. She is now, but back then she wasn't. So,
2 years
nearly 30-year veterans, and heavy in manual therapy as well. So we could, I guess maybe if you haven't seen all the podcasts, so you can review the article part one, and then we'll review the case.
Right. Well, so the article, are you talking about the one that essentially confronted my identity of a manual therapist to say that it's not working?
The article that cognitive behavioral functional therapy beat manual therapy in nondescript low back pain.
Totally.
Yes.
Yeah. And I was really, really mad.
Yes.
For a long time, and I probably read it 7 times.
Right.
To make sure I read it correctly. Because my whole identity was manual therapist.
Right.
And now it's telling me that it doesn't work as well as these other things that I have no idea in.
Right.
And that's when it was like, okay, challenge accepted, and I need to know what's the best thing to be working on this.
So pursuit of truth is important to you.
Totally, yeah.
So how do you do that?
Oh, I read a ton.
Okay.
I read a ton. Some students will know that I've mentored. I'll be sending them papers at 2 a.m., but I was feeding my daughter at that time, so what else do you do? But read papers, because I want to know. I'm curious, and when I think about things and I don't quite understand it, I need to know.
Right.
And it doesn't help just reading one article and being happy with it.
Right. So I think that's we're getting sidetracked a little bit, but just which is great, because I think that's what happens in PT a ton, or you're unable. We talked a little bit about this with Brahmat, but you're unable to read all of the literature. So an article pops up and you read it and think, "Oh my gosh, it's great," but it might be contrary to 900 other articles that said this didn't work. And so, without reading, you don't know the entirety of what's happening. So I think that's an important piece. I think consistent with Dan and Jeff and Jason and Andy and myself, reading is the most important. Yeah,
right.
Absolutely right.
When you hear it a lot from clinicians that are practicing in other places, like it's hard to keep up with the literature, but it's doable.
Yeah.
For sure.
Yeah. Well, I'm glad you said that. As a clinician, full time, just recently in higher ed. Really,
Right.
I mean, what, 6 months maybe? Yeah. So I mean,
Right.
I mean, you were doing 2 jobs at one time,
Right.
but full time in higher ed. Yeah. Well, I'm glad you said that because I think that gives some. Some value in the the people that are listening, whether it be an alumni or others, that it's still important to make time to read.
Right. Yeah, and I mean it's not spending hours,
Right.
but it's a lot of times you can sign up to some of these journals and they will send you articles, and
Right.
that's a lot of times what I've had to do for a time. Mom of 2 little ones.
Yeah.
There was a time that I'd follow specific people on Twitter and read that stuff coming out.
Right.
But that wasn't cutting it for after a while when I had a
Right.
little bit more time. But being able to get the fast access to some of trusted authors that I know and clinicians that I know, that's for a while I had to do that. I mean, you just have to find what works for you that's going to keep you up to date. Because it's changing a lot. I mean, compared to... I've been a PT for 7 years now, and the amount that's changed just in that amount of time, like, if I had not done this, I'd be way behind.
Yeah, it's not trivial. Right.
Right.
Yeah, that's a good point. So back to the case.
Yeah.
So we were all in there at the same time because it was part of the boot camp.
Right.
And Dan had a friend, if you will, that had some back pain.
Right. Some pigs. He had
some pigs. He worked on a little mini farm and was
Right.
a little weekend farmer and.
Right. Lumbar flexion.
Plus his other job, and so had been complaining for a while. Not a ton, but enough to have Dan concerned about his back, and so Dan offered to see him in front of all of us. So go. Yeah, what do you remember?
Yeah, so I remember pain with lumbar flexion. Couldn't really. I mean, very limited.
Yeah.
After some questioning, realized there's really no red flags, and had him try some strategies. Really, not co-contracting. I mean, that fear was that he had to keep his spine his muscles contracted to protect his spine.
Right.
And that wasn't the case. And so by just giving him a simple cue to not co-contract, he in front of us was able to go into lumbar flexion, full lumbar flexion without pain.
Couple of things, right? So as Dan watched him move, the behavior of how he moved, it was easy to see that, and we hadn't talked about this yet, I don't think, but the PTs instructing people on how to bend historically have says, all right, now tighten your core, and now I want you to try to bend and lift. The case.
Yeah.
Not only did Dan recognize his movement pattern, which I think is important as PTs, but questioned him on a number of things. And this is, I think, I guess I'll be transparent. I didn't believe in the psychosocial component. Well, that's not true. I didn't think of how powerful it was.
Sure.
Right. So there's elements of sure that I do understand that it influences people, but the degree, which was interesting to me, because before so he noticed how he lifted, part one, and then began to question him around personal family life events. Okay. And this is when this emerged. So we were all in the room and talked about moving from the city into a small acreage and being stretched a little bit financially, being able to make ends meet via a little mini farming. So they had some pigs and some other things, and that was going to help with the differential for being able to afford living out in the country. Is that right? Is that right? Am I getting getting the story right? And the more that Dan kind of listened to the story, it was evident that there was anxiety because of that.
Right.
And it came out, and this person had said, "I'm afraid I'm going to not be able to make finances, and I'm worried that I've hurt my back, and now I can't do any of the lifting that's required on the farm."
Totally.
And So it was magical, like you said. So Dan, I think he did touch him. Maybe just put his hands on his belly, and just a few fingertips on the back, and said, tactile, and said, "I'd like you to try something for me. I'd like you to bend this way, and so I want you to stick your belly out, and I don't want you to contract in any way, or try to stabilize your core. And I want to see what you can do."
Right.
And so, immediate.
That's magical.
So, meaning the way that the behavior of him contracting his core, stabilizing what he thought was the way to bend and protect your spine. And then subsequently, I don't know how many people we've seen, hundreds of people that bend that way, that end up having significantly less pain by not stabilizing the core when they bend. So that was eye-opening to us, and the way that that psychosocial component blended into the behavior, that flipped, I think, all of us in just really a very, very short amount of time. And this would have been 3 years ago, 4 years ago by now. So I think, probably close to 4 years ago by now. Yeah,
four, maybe even 5.
So a long time ago. And like I said, it's evolved since then, and it's rapidly changing, and we're trying to keep up and do what we can in helping students understand the complexity of all of it. It's not a formula.
No.
And I love how you're guiding students with the
more clinical reasoning.
Thank you. So you can cut out the little pause. But, what she just said was, the way that she's training our students is via clinical reasoning. So that is it'd be great for the listeners to know and CIs to know. We have a formula. It's an if-then formula, not a rote, memorized formula that includes, some OARSP and PP phone number.
Right.
It's around the way that we can practice clinically and determine what's happening. So,
yeah, it's clinical pathways.
Yeah.
But they don't always look the same.
Right.
Because it really matters what the patient has to say. And so when now being in the world of ClinEd, and I talk to some clinicians, and they're like, well, my subjective is the shortest part. It's like, well, it's my longest part. And so kind of my reasoning for that is, if I don't ask them anything, how would I know?
Yeah.
And there's a paper out that says the average amount of time it takes a PT to interrupt a patient is 11 seconds. So in 11 seconds, I did not allow you to give me your whole story, and each pain story is so different. So who am I to cut you short to say, I think it's this, let's go treat this with cat, camel, or bird dog, whatever. And it's like, no, if I need to know what you are fearful of.
Right.
And a lot of times their fear is nothing that I would have thought possible. And so really the clinical reasoning comes down what the patient is saying.
Right.
And then it looks different in the way that they need to do. Either they need graded exposure into whatever movement pattern, or I just need to watch them move.
Yeah.
But if I don't watch them move, how would I know where to go next?
I'm a big fan of that. Individual persons are individual in just that. And applying the same formula to a person doesn't work. So frankly, it might work for one or not the other. And here's something this is straight off the press. So brand new this week. It's not on the press, but it should be. So JD's been took your place in the clinic.
Yeah.
And so she's had 4 ACLs this week, and all of them have been filmed in the biomechanics lab. And so, and here's trained clinicians, so JD as well as Hauk, looking at people's movement behavior and movement patterns, and all of them fool us. So meaning we think that they're loading their knee. So when they put them on the force plate, and you're able to see that vector and seeing if it's going anterior or posterior to the knee, you realize right away that every single one has been fooling themselves and fooling the therapist in believing that they're loading their knee. And all 4 required individual movements that got them out of that false pattern.
Right.
So it wasn't the same activity.
Mm-hmm.
I used to do ACLs, hundreds at Oregon Health Science University.
Yeah.
And so we had an ACL group Monday, Wednesday, Friday, or Tuesday, Thursday, one of those I don't remember. It was a very long time ago. And then all the ACLs would show up during those, not all, but most of them would show up during those times. And so it was weeks of just dozens of ACL patients, every day, or every time they came in during those sessions. But we treated them nearly all the same.
Yeah.
And so this was eye-opener to myself and Hauk, and I think JD as well. Every one was different. Mm-hmm. A duck walk worked for someone, but it didn't work for another. A short, a single leg squat worked for somebody, but it didn't work for the rest of the 3. Right. Is that right?
Yeah. Yeah.
Nearly, right. So, I mean, they were so specific in the movement pattern required for them to break that abnormal cycle was, and this is a simple ACL, right? So now think of the complexity of the back. If we're applying the same model or phone number to that individual person, it's not going to work, flat out.
Right.
So.
No, it's interesting. And I challenge students and CIs alike, like those that are like, well, I have a protocol, so it's fine. It's like, okay, but what about the patient?
Right.
I mean, are we missing the patient? When did we forget about the person in front of us?
Right.
Because it's week 4, so we get to do this today.
Right.
And it drives me crazy, and I think it just, like, we can do better as PTs.
Right.
We're trained really, really well. We can sit at the table.
Right.
And, I mean, primary care has showed us that.
Sure.
The access, I mean, the access we should be getting with these patients is a whole lot more.
Right.
So, I completely agree. It should be individualized for sure.
Yeah, that's. I think that's just a good lesson for us to think about. Even something that you might seem the same as you've seen before, that it likely is uniquely different because of that person.
It comes down to dosage too.
Yeah.
Are we grossly underdosing?
Yeah, are we?
Oh yeah.
So how is your experience in that way that we're underdosing?
Oh my gosh, there's many different ways. But a lot of times it's like, well, you have pain, well then let's just rest.
Got it, yeah.
Or let's just do these seated exercises.
Right. Or this is our,
Therax.
our solar-powered TheraBand, and so we have the yellow here, right? And so...
yeah. Well, and it's interesting because it's like, okay, patients can do, say, the green band that's maybe 5 to 10 pounds. But they're able to pick up 15-pound dumbbell. So why are we still stuck on the TheraBand?
Right.
And I love having this conversation with students because that's where the clinical reasoning comes in of, okay, do I hand them this TheraBand or are they going to be throwing pigs at home?
Right.
So, I mean, you have to get that context, and you have to give the context to not only the student but to the patient, because unless you, I like to say, give them the license to move or allow them to experience something that raises their ceiling of what they think they can do.
Yeah.
They're not going to try it at home,
right?
Unless they've seen they could do it, or at least open the door to trying some more things.
Yeah.
It comes down to self-efficacy, but for students, think about what they need to do.
So you use that self-efficacy or clinical reasoning for. And link that to the performance that that person needs to do at home or at work.
Right. So, I mean, what does the patient expect?
Yeah.
And what do they find value in? My amazing Therax example of exercises I can give them is it's not valued to them because they need to do something that they actually find value in.
Yeah.
And then they're probably going to do the home exercises.
So how do you find that value?
Through my subjective questioning.
Subjective questioning.
Right.
And what do you use mostly?
Subjective questioning. I mean, I use a lot of MI, motivational interviewing, but a lot of times it's just trying to allow a space for them to get their story out.
Yeah, yeah.
I mean, talking to a patient just this week who's had 4 Toradol shots in 4 days at an ER, and just asking a simple question, so what does that make you feel like?
Yeah.
Which, some people might say that's psychology, but I just genuinely want to know what she is feeling.
Yeah.
She's like, well, I went in and they said I can have any medication I want. And so as long as I leave, they'll give me whatever. So it's easy to get a Toradol shot. And I was like, well, did it help? She's like, no, it's still super sore. Yeah.
Yeah. Complicated patient.
Super complicated.
Yeah.
But they're fun.
Right. Yeah. Yeah. Why not have a challenge?
Right.
Yeah.
But turns out it's not really actually her neck. I mean, she came in thinking it's still her neck, but through talking, it's like, I think there's a lot of other things that need to be addressed.
Yeah.
But you're not going to know that unless I had promise. One.
There we go. That's the word I was looking for.
Yeah.
So
well,
promise.
Pain
PROMIS.
interference was 83.
Yeah.
Fatigue was 82.
Right.
Anxiety 79. Depression 67. So we're high red flags or something else is going on.
Yeah.
It's funny because she was doing really, really well. So I thought, okay, I'm going to wean myself out because I don't need to be part of this care. I said, let's try for 2 weeks. And then she came back 2 weeks later with this. But a lot of other things happened. That's more psychosocially driven and more anxiety driven.
Yeah.
But had I not seen those numbers before, it wouldn't have clued me in to say, hey, there's something going on. I need to be asking.
Yeah.
And if patients aren't going to freely give that over until I'm asking the questions.
So you confront them on their numbers and promise.
Totally.
Yeah.
Yeah. I'm very open with, hey, on this iPad, you scored with this. It's not what I would have expected hearing like you're going for walks every day and you're doing this and that. And then I see a pain interference of 83. Let's talk about that because that to me shows, or even a physical function of 36. So you should be wheelchair bound.
Right.
But you drove here and you walked in. So let's talk about that. Like, what's your perception?
Yeah.
And so sometimes they just need a recalibration of their perception. It's like, is it in comparison to somebody my age, or is it to what I could have done in the past, but now I don't feel like I can?
Yeah.
Well, why don't you feel like you can?
I see.
Well, I have this fear that... Yeah. And her biggest fear is she doesn't want the pain to get worse. Well, it just got worse. It's 83. So and she's met her total fear.
And you didn't do anything.
No, I didn't.
Meaning it, to exacerbate it. It wasn't the thing.
But yet she just got 4 Toradol shots, but nobody actually stopped. And this is not a bash on anybody. It's just like, in healthcare, why are we not listening?
Yeah.
Because if that was a simple conversation to say, these are all the things that happened in the lead up to this crazy pain cycle I'm having.
Right.
And walked out feeling tons better. Just getting that off her chest to have somebody actually listen.
Yeah.
And I think as PTs, we're set up well to do that. I know in heavy, turnover clinics, it's hard.
It is hard.
You have 15, 20 minutes with somebody, and this obviously took a whole lot longer. But it shouldn't just be me asking that. It should be the whole team.
Right.
And so we went from 10 providers for this patient to 4.
Yeah.
So, I mean, there should be value in meeting the patient where they're at.
Right.
And it shouldn't just be one provider.
And we're fortunate that, we don't have to bill out like, other clinics for sure. But at the same time, we have the complexity here of patients that have, fallen through the cracks or have not had good communication, like with this person, that are amazingly complicated. So I don't know, the percentage of clinics are having these, very, very, very complicated patients. So we have the benefit of seeing them, and which is really powerful because you're making a difference. I've said this before, but I left Nike because I wanted to make an impact in the community. A shoe wasn't it for me, and I wanted to make a greater impact in the health of a community, that's why I love those that are unable to pay and those that are, that have been mismanaged, if you will, or just lost and need a place for that to happen. I get excited for that.
Yeah, me too. I mean, just my own journey. I did sports medicine, and with the...
So I wore the shirt, so it's the Birchbox Sports Medicine,
Yeah.
ATC background,
Right. So
professional athletes, college athletes.
D1,
So,
worked IAAF, super fun.
Yeah.
And it's still fun.
Sure.
Because you can really push them, and that's great. But primary care also switched me to that, because I think for me it was more eye-opening. I had never been exposed to see how much imaging gets prescribed, how much opioids get prescribed, and sitting in that room and the doctors looking at me and say, so do they get opioids? And I'm the one that's the gatekeeper.
Right.
Or the
patients, shot or the x-ray. Or
Totally. Right. Yeah, and the patients, a lot of them being really, really mad to just say, hey, if we just did 15, 20, 30 minutes of walking every day, these things, like, it's not musculoskeletal driven.
Right.
We know there's benefits with physical activity, so I say no, but the doctor can still, decide.
Yeah.
And I've had a lot of head-to-heads with one doctor in particular about injections, which has turned, because he used to give the injection before he called me.
All the time, right.
Yes, and so had the conversation to a point where at times I beat him to it. So that was fun, and I mean, it's about elevating everybody, right? It's not just about PT, or it's about elevating everyone so that the patient experience is better.
Yeah, one of the things, and this is again a skewed sample, and we saw nearly 1,000, and so it's a large population.
Right.
And again, it's skewed in that the people that we saw, most of them failed physical therapy. So that was disheartening for me, where they were referred to physical therapy, and then this was their next visit with their doctor, or third, or whatever it might be. And so, part of our questioning when we were there is, well, have you tried physical therapy? And most had tried physical therapy and failed, and that was disheartening for me to hear that whatever they did in therapy was not successful, and didn't them as a person felt like it was not of value. So that's we had to. I think at some level, the brand is a little broken. And we need to fix that, and I think leveling up like that, so shout out, leveling up, not necessarily Zach stuff, but leveling up in that way is important, because it flipped the doctors. So because the doctors hear that, PT didn't work. Okay, PT didn't work. How many? I mean, hundreds of patients, told the doctors that PT didn't work, and so. We were really behind the 8 ball early, because some saw the value for sure, and we had personal connections and relationships with a couple there, and which got us into. But it didn't take long. Well, I don't know, 6 months. It didn't take long. I don't think that's long to flip. The one of the physicians that's their MO was injection. And so it was a series, like you said. They used to say, well, here I injected them, and then now go see Li-Zandré or Tyler or whatever. And then, 6 months later, it's like, well, can I have them first? And then they agreed.
Right.
And so, and then winning with that patient so that they didn't need the shot was a big deal.
Yeah, I mean, it comes down to trust, and talking with some other physicians who's in that same group, it's about how much do I trust you with my patient who has potentially already failed, and that was very disheartening and like a dagger to hear that we failed somebody.
It was really hard to hear that the percentage of people that we didn't get better was hard to hear.
Right.
Yeah.
And I love the conversations to ask, like, why didn't it work? And it doesn't work for everybody, and I get that, but it comes down to dosage.
But the reasons, and this was exactly where you're going with that. So the reasons why it didn't work were
passive modalities
mostly, or just like you said, the dosing wasn't efficient to cause a physiological effect. You've got a yellow TheraBand trying to strengthen some body part,
Right.
where it's so inconsequential to the daily activities of what they're doing. Right. It's never going to work.
Right.
Yeah.
And I mean, full confession, I used to be that clinician that said, you need to pull your belly button to your spine. I even taught a class about it. And like thinking back now, the amount of patients I've seen since then,
yeah.
I'd say, hey, there's this new way that we do things, and we actually want you to push your belly out. And then they look at me like, but you said, I was like, I know, and I have to completely confess I did. Yeah. And at that time, that was the research.
Yeah.
But right now, this is the research, and I think the humility of having to say, you know what, yes, I did teach you this, but now we're going to do it differently, because you don't need to be co-contracting when you're picking up that pen, or when you're loading the dishwasher, because it's not. Right. You don't have to do that. Right. So it's taught me a ton of lessons too. I think being willing to flip quickly on beliefs that you carry would be it's been super valuable for me to be moldable, and it's going to change, and things that you hold dearly.
But you self-reflect a lot.
Oh yeah.
Right. So and I think that's so when Dan and Jeff and I talked about the time that we got flipped, we all knew that the manips didn't matter. Yeah. Or the osteopathic, because we all got the gap somewhere, or the rotation was wrong, right? It's not this, and it's this innominate, and then so it's this sacral torsion, but I put him in this position for the other sacral torsion, and it still worked, or the other way around, it didn't work, right? So it was hit and miss on why it worked or didn't work. So we all recognize that as seasoned therapists, in practice, and knowing that there's got to be something else to, half these patients, that's probably something else and not mechanical. So
yeah, I mean, I'm super blessed and thankful that I got it so early in my career, or at least like my eyes were opened by tons of mentors like you guys. And I sometimes wonder, is that the reason why we have burnout? Yeah. Is because, I mean, at a stage in my career, I was willing to leave PT altogether. Yeah. And so thinking back, is it because... And
that was just 2 years in.
It was 18 months in.
18 months in.
Yeah, I was ready to completely... Because I think you're excited when you graduate and you go out and you're like, I'm going to do all these things for my patients. And then you get to a point where it's like, is this really what I signed up for? And if it is, I'm done. So I was at that point at 18 months post-graduation. Loved my colleagues, hated going to work, and that was like a big pause of, I love my patients, I love the colleagues, but why do I not enjoy what I do? Yeah. And it was a big moment of reflection and questioning God for some of the things that I thought was so set in stone to be completely different. And it's so, like, the journey is beautiful, and I don't regret anything. I'm actually super thankful that I've had to go through those so early in my career, because it allowed me to get here faster. I wonder about burnout with clinicians because of that. Like, we do like what we do. It's just
the external pressures now are much more than in my day, or even just 10 years ago, right? So even maybe 5 years ago, the pressures for reimbursement and things like that are hard for clinics. I get that. Hard for therapists. But I think there are solutions.
Totally.
Yeah. So health and wellness solutions, opening it up. I mean, why can't one therapist? I think we talked about this last time. In a clinic of 5 or 6, a couple hours 1 day a week it would really need to take to have group and do these things to have more evals, because most of these clinics have waiting lists, and waiting
like
lines.
3 months.
That's long. Some of them are very long.
They should be better by 3 months before they get in.
Most likely they are, right? But they come in anyway, and they really actually don't need treatment. So that was part of some of the stuff then. Learnings in primary care, we do this PASS questionnaire. Essentially, do you think you really need treatment or not? Right. and it's worded a little bit different than that. Or can you manage it well enough without, being, I don't exactly remember we don't necessarily have to read it.
Right.
But most people, it was greater than 50%, said, yeah, I can manage it fine. Well, then why are you here? Part one, because, the doctor said, or whatever it might be. So you're right, many of them didn't need to come anyway.
Right.
Yeah.
Well, and if you look at all the amount of waste that happens in the U.S., $1 trillion. And
and how many was only like $1 billion of that was fraud or something, or not even? Right?
Yeah,
so
very little.
Very little. I don't
less
think,
than
I think
what I thought would be for fraud.
Yeah,
if you look at value-based care, or even just like simple physical activity for some would be the big one, and then public health. There's a lot of that could be and should be managed maybe differently.
Yeah.
But I heard a quote early this week, I think, and they said reassurance is the greatest painkiller.
Oh yeah. Well, that's great, because that was our experience in primary care.
Totally.
And I know there's different frames for the psychosocial component of that, whether it would be fear-based or motivation. There's lots of ways to communicate, and so I'm not adopting a particular one. But for me, that was the eye-opener too. Yeah. They came in, and I guess we learned that from the physician. One of the physicians, and this is really great, because how did participate, of course, in primary care. Not as nearly as much as you, for sure. But I remember, the physician saying, I'd like to know, what they're afraid of. And so, how 6'2", 6'3", walks in, opens the door, bursts in, and says, I'm here to address your fear, right? And what are you afraid of, right? And so, because I think that's it, the assurance that they're not going to end up like their uncle, they're not going to end up like their aunt or their father or someone they knew that was debilitated because of this injury, and that was eye opening for me. And if they believed you, it was immediate assurance. And they were able to move.
Right. And I see that here, too. It's why we've been able to do so many one-time visits.
Right.
They haven't seen their physician. They just walk in, hey, I have this shoulder pain. And then, I give them promise, and their promise scores are fine. So I walk in, it's like, so what are you here for?
Right.
Because,
which is great. Great question.
Right. I want to know, because subjectively, your patient-reported outcome is telling me that you're okay. So what do you need me to say? And so, sometimes they're like, I just need to know that I didn't tear my rotator cuff.
Right.
And so you do a simple drop arm. Not even a specific special test. You're just looking at movement. Yeah. You're like, I can tell you right now it's not torn. Like, okay, well then I'm fine. It's like, oh, that's it. Yeah. Right. And so, I think as PTs, that's sometimes like, but I have all this knowledge.
Yeah, exactly.
I can teach
here's these exercises
I've learned
with the yellow TheraBand. Here, watch. You can take this at home. And
right. And so, they don't need me to do a ton for them. A lot of times it's like, well, you're good, and in case something happens, like a lot of times they don't even go with exercises because they don't need it. They just need to know it's not torn. Right. Or, they've seen their mom or somebody go through back pain, and they have this tunnel vision of this is my life in the future. Right. And that is really fearful, especially when you're 20-something or 30-something, that I don't want to end up that way, and that's valid.
Right. Yeah. So. Yeah. Where else are we going? So we talked about promise.
Yep.
Talk about, we've briefly talked about promise. Mm-hmm. So, how do you use promise? Straight up.
Straight up, I use it all the time.
Every patient.
Every visit.
Every visit.
It absolutely dictates what I will be doing with a patient.
Say that again.
It absolutely, and capital bold letters, absolutely dictates what I do with that patient.
So why flippin' PTs not happy with that? Because I don't get it. We've done the dog and pony show with Promise for 3 years now, and I fell in like with it, fell in love with it. The moment that Jeff talked about the power of what it can do, and in so much as it dictates in bold what you're going to do with that patient when they come in. So,
I mean, like usual, I'll have my A and B of we could do these things.
Sure.
Just so I'm not like deer in the headlight, just like what am I going to do? Because I'm self-reflecting all the time on these patients. But I just can't. I've learned a lot now to be able to pick up on things if I didn't have promise, but I still would prefer to have promise all the time.
Yeah.
It brings value to the session.
Yeah.
It highlights things that I would never have known or I wouldn't have known to ask.
Yeah. That's it. And the domains that we have, there are 5 simple domains. Are we doing more than that? I'm not.
Yeah, I do 5. So
domains,
I do pain interference, physical function, fatigue,
Yep.
self-efficacy, and then social roles.
Right.
If they are really high in fatigue, we've done some research and it comes down to multiple things about why fatigue is high. And if you think about it too as a PT, you don't ever get a patient that comes in and say, hey, I'm tired. What are you going to do for me?
Hardly ever, right.
But when you ask them, they're like, well, I'm just so tired, right? And they're subjective. They keep saying it. And I never addressed it because what do I do?
How do you do? Right, exactly.
I was never told what to do. Like, yeah, you're tired. I'm tired too, right? So
I have 2 kids. I didn't sleep last night.
Totally. I never did anything.
Right.
Until I said, hey, this fatigue thing we keep asking about.
It keeps popping up.
Why is it so high?
Right.
Like, yeah, they're tired, but is there other reasons? So I went to Hauck. I said, hey, I need to know what I can do for fatigue because I don't know.
Right.
There's not much literature out there. And what is fatigue?
Yeah.
Is it just tired or what? And so we start looking at it a little bit more. It comes down to sleep disturbance.
Yeah.
Sleep-related impairment like sleep apnea.
Yeah.
Which we actually found sleep apnea in a patient. Well, we didn't find it. We encouraged them to go do a sleep study because their fatigue just kept skyrocketing.
Right.
And the other one is depression, anxiety, which is huge. I mean, I think after 2020, it's been trending pretty high for a lot of people. Or there's hormone imbalance or thyroid. I mean, there's a lot of things, but it opens it up for some more questioning.
Communication about what it is.
Right.
That for me, that was the value of promise. They answered the question.
Right.
And they opened the door for you to talk about these things.
Totally. And patients a lot of times say, nobody's ever asked me about this.
Right. How many, a large percent say that because we've not asked the right questions along the way.
Right.
Even in maybe a comprehensive subjective eval examination, we still haven't asked the right question. You can imagine, it's specific about self-efficacy of your symptoms that you're experiencing.
Right.
That's never brought up in a subjective exam.
Yeah, one patient I can think about. So early on in my career, I'd see thyroid medication. I'd just skip past it because what am I going to do about it? Yeah. So this one patient was really high on fatigue. I was like, hey, I noticed that you're high on fatigue, but you're on thyroid medication. Yeah. Do you feel like it's managed well? And she just sat there and she's like, my doctor doesn't even ask me that. No, I don't think it's managed well. Right. It's like, well, okay, that's not my scope, but you should talk to your doctor about this because who knows if that's maybe what's causing your fatigue and they can do lab work and stuff if they need to, but maybe it's just simple medication or let's move.
Or and I like that about what PTs can do with fatigue, and it's really about movement.
Right. Yeah. So we. At times they get screened for 9 things, and it's helpful for me because I have data, I have numbers. Nobody can argue the numbers like how it says.
And it's their numbers.
It's their numbers without my input of, I think this is what's going on with you. And I think a lot of times as PTs, and I think Hauck asked me this very early in my career too, but it's not about you, is it? And I still remember it. So at times when I feel like, is this my bias?
I think you asked JD recently about that too. Right? So it's powerful.
Yeah, it is. And I think the moment that it's like, is this me or is this truly what the patient values or expects? And that's my checkpoint. Really is.
We often, and when I say more than often, it's a regular occurrence that PTs interject their own ideas of what that is and how to fix it. And it's nothing to do in large, about the patient or the person in front of you.
Because we think we know.
Right, we do. But not to know. Oh,
right.
You do these tests, you do these things, it's probably going to be this. So we go, whoop, we go right to that. We discount all the story, right? Well, once, like you said, every 11 seconds, because you hear, okay, oh yeah, that's the little thing. Now we can go here. Okay, stop. Right. Okay, now we can go here.
Right.
And so, I mean, that's how we're trained. So I don't know that we can blame, the therapist for that, because that's our training, is to, to kind of figure out, what that problem is right away.
Right. Well, I think, like, if you come back down to students, because they ask me all the time, like, how do I make that jump? And I think illness scripts are great.
Yeah.
To a point.
Sure they are. For screening, they're wonderful. Yeah. Absolutely.
Right. But it should not be your driving factor of treatment.
Right.
So, you need to know your differential really well.
You do.
You need to be able to screen things out in real time, and that's why I push clinical reasoning so much, because if you're still sitting in your subjective questioning, and then it's like, wait, okay, so they said this, and what's my next question? Well, I just forgot to listen to what you just told me.
Right.
And I know in students, like, they're still learning, and that's great, but a lot of times their answer is going to lead you to a different question.
Right.
So, it's hard. I was a student too, thinking like, oh my gosh, let me just get the next question right, because my CI is right here, and I need to ask the right questions in the right way, in the right format, my
in
little,
the right order,
in my alphabet, and then we forget what the patient said.
Right.
And I see it sometimes too when they ask similar questions, but the patient's already answered it. And patients will look at you too like, wait, I already answered that. But then they'll be nice enough and answer it again because it's a student. But then I'll know, okay, well, let's recap, right? Let's talk it out. What are you thinking now?
Yeah.
And then you go to objective, and you don't need the special tests because you're watching them move.
Right. So I got a question for you.
Mm-hmm.
So what brilliant plan did you have for bringing in 44 patients a day into a clinic to do a integrated clinical experience for our students, and how and why are we doing that? So
why are we not doing
tell
that?
us a little background. Oh, that is so good. I love that. So Li-Zandré and Paul decide to rethink Clinet. So it's a love about our program is we're always thinking about the future and how to make better therapists. And they came to me and asked about training of students. And oftentimes we spend a whole year with them and then send them on their way to try to practice in various settings. And it's not hit or miss. We've been selective with the clinicians that we use, the clinics that we use, the CIs, and then we've trained most of them. So it's not an observational experience, although I think some slip through the cracks a bit, and that become some observational for those 4 weeks outside of the clinic. I'm sorry, after their first year. You wanted to flip it. And you wanted to do something totally different. So why?
Good question. So I like a challenge, obviously. But, so our students are great.
Yep, they are.
They are amazing. And when you raise the bar, they step up.
Yeah.
So how about we raise the bar on their first rotation is really my first thought, because being in Clin-Ed too, you talk to these clinics like, well, I really don't want a first year. It's like, why not? Because they're amazing and they can do a lot. So I think we underestimate how much first years know. They've got all the foundational stuff. It's fresh. And why not build on that?
Yeah.
Instead of saying, well, your first year, you haven't really done XYZ, so I'm just going to have you sit here and watch me do it. No.
Right. So tell us a little bit about what's going to happen.
So we have 44 students.
Yep.
We have 11 clinical instructors. So that's, if you're doing the math, 4 students to a CI, which is also different. CIs don't usually like to go more than 1.
Yeah.
We're kind of pushing 2-to-1 model because research shows it works.
It does work.
So 4-to-1, more medical school model.
Yep. Residency model. Yep. Yep.
Right. So not only are we expecting to raise the bar on them, but it's peer-to-peer. So they can help each other out and level each other up in that regard too. They have more people to bounce ideas off. It's not as intimidating to go to your CI. And it frees up the CI to be a whole lot more of an educator versus the clinician, like you watch me versus I'm going to watch what you do and help you
in the next steps
push for the next thing. So that is my big hope, is that becomes a reality and that they actually get the exposure and experience that they really can handle as a first year. And if they can't, well, there's a licensed PT that can bridge that gap. Like, students are really good at subjective and objective. They get better as they get more schooling, and then they can do an amazing treatment. But they have that hard time to either, whether it's self-efficacy of the clinician, the student in the case, but or fear of like pulling the trigger of, I think this is what's going on and this is what we're going to treat. Maybe just giving them more confidence of start realizing these patterns. And we've had a couple that have just observed for 4 weeks. This, like, let's level them to an even playing field by the time that they go out in the second year. So
we had a little pilot this fall.
Did?
And how'd that go?
Amazing. Yeah, we only had 6, so COVID threw a wrench in a lot of clinical education, but we rallied and everybody went out. And so
all but 6.
All but 6. So they did the fall thing, fall clinical experience, integrated clinical experience. So every Friday they saw patients with Dan, Kang, and myself, and we pushed them. We pushed them pretty hard, and they rose to the table. I know it's hard, right? Second year, so they've got a week of classes and midterms, like that does not stop, but they're still in the clinic, and we saw some really complex patients, and there's times that you can tell, like, I'm just not ready for that, and it's okay. I mean, it's a give and take. In the beginning, needed a little bit more guidance because they've never been out. But at the end, there are some treating independently, doing full evals by themselves. I mean, it's like I just sat there watching and just like super encouraged by what they've learned in just a couple of weeks. I think if you show them that you have trust in them, they don't want to lose that trust, so they're going to keep pushing.
Cool.
It was great. They did amazing in their second year rotations, and frankly, we told them, like, your CIs should be scared right now because you're not going in as a second year. You're really third year level.
Cool.
So it was fun.
Very fun.
Yeah.
All right, so you came with the list. So did we hit everything on your list? She came prepared just in case we asked her hard questions.
No,
she wanted
I was
to be
winging it.
You want to be ready. So
yeah, I mean, I think the biggest thing when it comes back down to access to care and primary care, which, you know, I think the future is amazing for, like, we should be in there. We should probably be in urgent care too, or emergency rooms, especially for these neck pains that come in for 4 shots, 4 days. Insurance companies are picking up on it. I mean, not only is it working, but it's cost effective. And so, I mean, there's PTJ just had a meta-analysis looking at cost effectiveness of seeing patients either before they've seen their physician, so true direct access, which we have here. They have on average less appointments with PT versus the having seen a physician first and being referred with a diagnosis. So that was kind of fun.
That's interesting. I had not read that one yet. So
so kind of fun looking at just cost effectiveness, and insurance is going to start reimbursing. You know, if you've seen a PT in primary care, you're going to get reimbursed. Well. So
cool.
Yeah, I mean, they're picking up.
That's exciting because we have 5 primary care clinics that we've started, and the future looks bright for more. And it seems like our students are positioned well to kind of take leadership roles in these primary care clinics, and so we're excited to see what the future has for students in our program and the profession. So cool.
Yeah. No, there's a ton of fun things on the horizon for PT.
Well, thanks for being here.
You're welcome. Thanks for having me.
Certainly. Are there any last parting shots you want to do across the bow, or what's the future? What do you? I mean, it doesn't have to be anything, but we're happy that you were here, and this is what I tell people, and hopefully JD doesn't cut this out. But I want them to be, our students should be little Li-Zandrés, and I tell her that because it's absolutely true. We want we want the best for our students, and Li-Zandré is such a great model for that. So
well, thank you.
Yeah.
I did not see myself in academics at all.
Yeah,
but it's I feel like it's a calling now.
Yeah, cool.
Because love the students. They teach me a ton. They keep me accountable because they're really smart.
No, they do. And if you're not up on your stuff, then that's shame on you.
Yeah.
Yeah, because we should be giving our best to the students.
Yeah.
Yeah. Yeah. All right. Thank you.
That's it. Thank you.
Yep.
And I would never cut that out because it is very true. All right.
Wow. Great topic today. Great conversation today. Thanks for listening. Thanks for tuning in. And just make sure you're connecting with us in some way, whether it would be liking or subscribing. You can connect with us directly, and be sure to visit our website, motifcenter.com. And if you want to be featured in our Q&A, send us a question. We'd be happy to answer that in our Q&A session, and let us know where you're coming from.